I was told to present this topic, strategies of improving vascular access outcomes. And we have a mixture of audience. So I was now, undecided what to do, put a lot of studies or get into hands-on, what do you do when you have a patient whose vascular access is an issue? So I thought, hands-on, interactive kind of a session would be more interesting and more sticking to the brains. You're all tired of all those huge studies, which sometimes I think doesn't make sense to me. So vascular access is a mainstay. It's a backbone for dialysis. If you don't have vascular access, you can't do dialysis. And we unfortunately only have 3 types of vascular access. We have the arteriovenous fistulas, arteriovenous grafts, central venous catheters, either tunneled or temporary. So, why do you do arteriovenous fistulas? You want a big vein. You want an arterialized vein so that you can take blood from there, clean it up, and put it back, right? So, and I said, this is a lifeline for a patient. And if it goes, it is shown that the mortality increases if you don't have a good vascular access. And if you get it right the first time, then your patient's mortality, morbidity decreases, right? Just imagine, just vascular access can cause, inadequate vascular access problems can cause mortality. So what's our main aim as doctors? To reduce mortality. And if we can get this right, we are reducing mortality at a big number. I was wondering why they call lifeline. I just got this photo. Is this why they call it a lifeline? I don't know if the patient falls. So KDOQI came in with new guidelines. The last guidelines were in 2006. The newer guidelines are in 2019. A little more update than what it was in 2006. They are almost 30 statements. Okay, so we'll go through each statement. No, I'm joking. We won't go through each statements. So I'll just say a few of them, and then you can go back and read them up. They're quite interesting, quite a lot of new things. So as I said, end-stage renal disease, patients with end-stage renal disease have to have a life plan and a vascular access choice. So when do you send these patients for a vascular access? Okay, we usually know patients when they reach the eGFR of around 15 to 20, and KDOQI actually recommends that. So progressive CKD and or an eGFR of 15 to 20, they need to have a planned vascular access. And every time this vascular access plan should be reviewed with the patient and with the healthcare. Dialysis is not done by one person. It's a multidisciplinary business. So if you have a multidisciplinary team, it has again shown to have better outcomes with patients on dialysis. And then regular monitoring of these patients is also very important. So what is the best vascular access for your patient, right? Is it a CVC? Is it a fistula? Is it a graft? And again, so we'll go through this a few diagrams here. Unfortunately, I'll just point here. So these are patients pre-kidney replacement therapy and considered for hemodialysis. What do you look at? What is the likelihood of this patient to survive? Is the patient going to survive more than 1 year? Consider the age, the comorbidities, the functional status, the social support, and the patient's goals and preference by themselves. There's a lot of conservative management to these patients nowadays. Patients who are 85 years old, 80-year-olds. Unfortunately, in our units, private units, they still dialyze. But in the West, these patients have now gone into more of a palliative kind of. So if you don't think the patient is going to survive more than 1 year, then so then if the patient is not going to survive more than 1 year, so you can either consider an AV graft or a central venous catheter, because these patients' fistulas are not going to mature and you'll have more trouble. You try putting fistulas in these patients, they won't mature, the patient won't like you, patient will spend a lot of money. So just go get a nice first time tunnel catheter. When you start your dialysis, don't start with temporaries 1, 2, 3, and then go into tunnel. Just go tunnel first time. And then again, for these patients, if they're going to live a little more than 1 year, then you can consider graft, which has better, chances of being used than a fistula in these older patients. So, but if the survival is good, then obviously AV fistula is your choice. Okay. So, and then go ahead and do AV fistula. And then you can always reassess these patients every time the patient comes to you, whether it's once in 3 months or something like that. If the status is improved, the patients, let me give an example. Patient had breast cancer. You don't know whether the patient's going to survive more than 1 year. You put a tunnel catheter. The patient was cured. Then you can go and do a fistula if that happens. This is what we see a lot. Okay, our patients have already been started with a CVC, right? Most of our patients in this country, let me say 80 to 90%, start with a CVC, unfortunately, because many of them are crash starts. Many of them lethargy. There's a huge topic again, why these patients don't start with fistulas, lethargy of nephrologists, not appropriate referral to a vascular surgeon to do the fistula. So let's say a patient was started with a CVC, and then you check if your AV access is appropriate. There's no central stenosis. There's potential, vessels. Then go ahead and do a fistula. But if you have all these other issues, which we usually have, you have already central stenosis. The veins are quite small. Then you can continue with your tunnel catheter. Again, reassess this every time the patient comes to you. So, the newer guidelines are not banning the tunnel catheters completely. That's an interesting thing. So, some patients will still require tunnel catheters. Some patients will do with the fistulas better, and some patients with the grafts better. So we have a lot of the time failing AV access. Most of our dialysis units here, vascular access is a big issue in this country. So patient using a CVC, yes, see if your AV access is appropriate and possible. Again, if you already have stenosis, anatomic barriers, potential, inappropriate access locations, and medically or surgically feasible. If it is, then go ahead and assess this patient if he's a good candidate of AV fistula. How do you assess that? Again, age, comorbidities, vessel suitability, vascular sites available, prior access failure, and future access sites and possibilities. If it is appropriate, then go ahead and get your fistula done. But if not, again, you can reinsert your CVC or reinsert your, by CVC, I mean reinsert your tunnel catheter either at the same place or a different place. And if the patient has that, but is not a good AV fistula candidate, consider an AV graft, okay? So to make it a little interesting, I'll give you a case here. And this is like our bread and butter. 57-year-old female end-stage renal disease secondary to diabetes on hemodialysis, has been dialyzing via a right internal jugular tunnel catheter for the last 6 months and comes to the dialysis unit with no flows from one port. How many of you have seen this? Wow, like almost 80%, right? So unfortunately, who gets the call? The doctor, the nephrologist, poor nephrologist. And then what do you do next? I think it's a poor nurse who is there with the patient rather than the nephrologist who is sitting in his office. The nurse is more stressed usually, isn't it? Yeah. So look with heparin for 1 hour and try again. Look with streptokinase, flush the catheter, get a big syringe and just flush it off, change the catheter or the guide wire, or fix a new catheter on the left internal jugular. So we'll see how we can prevent this kind of things, okay? So a few tips for insertion of tunnel lines. I mean, what's the usual standard, okay? So unfortunately, we use a lot of temporary lines. Temporary lines should not be used for more than 2 weeks. Has anyone seen temporary lines used for more than 2 weeks? Oh, really? So I'm getting I'm getting somebody saying 2 years. What? What? I'm gonna collapse. So use an ultrasound to fix your line. Okay. This is for the tunnel lines, and if you can, for the temporary lines as well. Yeah. So you don't, every puncture in your vein is a source of infection. The best prevention of infection is your skin, right? And every puncture is a puncture through the skin. And if you're there, you're just putting your needles 1, 2, 3, 4 until you get on the 4th attempt, source of infection for sure. Okay, so if you have an ultrasound, you get it first time, this is the patient's life, the mortality. Okay, patient gets an infection from the catheter, mortality goes up. Use of fluoroscopy, and then we've had patients multiple temporary catheters, get central stenosis, and then you send them for a fistula for the poor vascular surgeon to sort it out, which is very tough, very expensive for the patient. So again, environment, okay, not on the side room somewhere. This is ideal. We should try. Okay, now that we have so many dialysis units coming up in the country, we should try to observe at least sterility. So that's where I fix my tunnel catheters. I'm lucky to be there. If you've seen, your patient has been draped, proper draping, everything is in a sterile environment. You're using the ultrasound there. You know exactly where you're going into the vein, right? You're not doing it blindly. You have a fluoroscopy. You've put your guide wire right into the IVC. Can you see it there? Yeah. So that if you don't see that, your guide wire might go into the azygous vein, might have gone into the other left side, and then you're fixing a tunnel catheter. It's going to be tough. Usually, and if it's a first case of tunnel catheter, doesn't happen, but we have seen it happen as well, right? So you've got a nice catheter there. And one more thing, the exit site, okay? One thing to avoid is suturing if you can. Don't suture the exit site. Just make a small nick, okay? You don't really need to suture this. This thing won't come out because you've already sutured it here. Okay, so here, this patient had a suture here, and look what's happened. Can you see that? Because people forget to remove these sutures, right? People forget to remove these sutures. People forget to remove these sutures, because then if you don't remove these sutures, you can't clean under the catheter, okay? So small things make a big difference. Again, catheter I've seen catheters exit into the axilla. The patient is putting the catheter like this, right? Axilla is not a clean place. So try to avoid the axilla, okay? Don't do your catheter right there. It's difficult for the patient. Again, it's dirty. If you can get a good curve onto the chest wall, that's better. So this is how to access the catheter, and how to connect and disconnect. And I think this is a very good one for our nurses who do this every single day. Most of the nurses are quite expert in this. And we are fortunate, maybe we are blessed that we don't get, if it was in the Western world, probably we'll be getting lots of catheter infections, more than here, probably, I don't know. So again, how do you access the CVC? You have to explain the procedure to the patient, turn the head of the opposite direction, hand hygiene, very important. Remove the gauze or tape securing the CVC, ensure that both the CVC are clamped, okay? And then place a sterile pad or towel under the CVC so that the limbs are on top of the pad. Perform hand hygiene, okay? Put on sterile gloves. So again, remove, the lock cap, clean the hub. That's also very important. You just don't go, all right, we're in a hurry. You're like many patients waiting. Without cleaning the hub, you go again and so ideally with chlorhexidine, okay, or povidone. And again, ensure that the disinfected hub does not touch non-sterile surfaces, okay? These small things make a big difference, okay? And I'm sure most of the nurses do these things they're much more expert than we are. And if anyone wants this, I can give it to them so that they can have a look. Again, how to disconnect. It's a way how you can disconnect the catheters in a more sterile way. So obviously they've compared mortality between AV fistula, AV graft, and central catheters. So who thinks central catheters are better than AV fistulas? Good. Who thinks AV fistulas are better than AV grafts? Excellent. So, they've shown it here. So, on this side of the chart, catheters favored, fistula favored, okay? And most of these studies actually favored fistulas on mortality. So they checked at mortality with AV fistula, AV graft versus CVC among patients. So almost, if you look at there, 40 to 50% higher mortalities with central catheters versus fistulas or grafts. So how do you get a good fistula? How do you get a good graft? What do you do? Okay. So physical examination is very important. When you've already got the fistula, regular physical examinations of that fistula or a graft, it's quite important. And we'll look at how you examine these fistulas. If you have any problems with these fistulas, refer them to your doctor, refer them to your vascular surgeon to help you out. So again, these are the latest guidelines, 2019, published in AJKD 2020. So again, a physical examination is quite important, and we have to pay a lot of attention now that we have our training programs as well. The East African Kidney Institute, our fellows, they have to get some training on how to examine these patients. Again, vascular mapping, quite important before you plan for a fistula. If you don't, map your vessels, if they're less than 2 millimeters, you go ahead and do your fistula. It doesn't mature. The patient's not going to like you, okay? Because we already financially constrained, and if you lose any site of fistula, you're losing. My mentor, Professor Tushar, says you're losing real estate. Okay, you have real estate of your hands. If you lose any site, you lose that site. You go to the next site, the next site. So every time you lose an opportunity to get a good fistula. So I won't go through this. More of a, so what is a good fistula? Okay, during maturation, the rule of 6. I know everyone knows this. So when a fistula can be used within 6 weeks of creation, that's a good fistula. It's more than 6 millimeters in diameter. That's a good fistula. It is not deep. It is within 6 millimeters from the skin. That's a good fistula, and it can sustain at least 600 mils per minute of blood flow. That's a good fistula. And a fistula which has at least 6 inches of outflow vein. Now that's very difficult to get, 6 inches of outflow vein. Some patients get it. So if that's the case, then your needles are far apart. You have less recirculation. So that's a good fistula. So get you another case here. 65-year-old male, end-stage disease, again secondary to diabetes, on hemodialysis for 6 months. The dialysis nurse, regularly checks the fistula, and this time realizes there's no thrill. You tell the nurse to send the patient for an ultrasound, and the fistula is thrombosed. You get a call. What do you do? Any takers? What do you do? Send it to the vascular surgeon, right? It's easy. Okay. So what to look for in an AV fistula? How do you examine an AV fistula? So I'll go through that, and that will be the end of our talk. Okay. So who's responsible for this? Okay. Patient, nurse, doctor, all of us. It's a team approach. As I said, functioning AV fistula is equal to the patient's life. If AV fistula fails, you guys know how difficult it is to get another vascular access. And in between, the patient can die, okay, without dialysis. Again, if you have good AV fistula examination, you detect these problems earlier. Maybe the patient who had a collapse or a thrombosed fistula, if he was examined earlier, maybe he had some outflow obstruction, was sent to the vascular surgeon, the patient couldn't have got the thrombosis, right? And then it equals to saving. So again, it's reiterated in the KDOKI guidelines that regular physical examination or check of the AV fistula by a knowledgeable and experienced health practitioner to detect clinical indicators of flow dysfunction. And this is strong recommendation, all right? And then KDOKI considers it reasonable for nephrology trainees and health practitioners involved with clinical HD patient care to properly trained in physical examination of AV access. So what do you look at in these fistulas? I'll just go fast from this, and then we'll go and look at each and every detail. Okay, so physical examination, you look at ipsilateral extremity edema, alterations in the pulse. If a pulse is weak or resistant pulse, difficult to compress, then you know there is some stenosis somewhere. Abnormal thrill, again, you know there's a stenosis somewhere. Abnormal bruit, stenosis, failure of the fistula to collapse, and you know excess collapse of venous segment upon arm elevation. So all these point out, we'll look at what they mean. Okay, and then during dialysis, new difficulty with cannulation when previously it wasn't a problem, you know there's something going on in this fistula, you need to do something. If you aspirate clots, not very uncommon, right? Yeah, so inability to achieve the target dialysis flows, prolonged bleeding beyond usual. Again, this can be a sign of stenosis, and then unexplained decrease in delivery dialysis. Your KT over V goes down for more than 0.2 units, then you know there is a problem with your vascular access. So a physical examination, ideally 4 to 6 weeks after surgery, you know, you can identify primary failures, plan for early intervention, and plan for surgical revision or new access. And before every HD session, please examine your fistula, okay, for any thrombosis, any prolonged bleeding, and inadequate dialysis treatment. So again, you know, AV fistula is just not here. It's the whole system until the heart. You know, it starts here and goes right. So you have to think, you know, you can have a stenosis here, and if you examine all through, then you'll figure it out. You'll see, you know, collateral veins, and you know, pick it up earlier, send it to the surgeon to sort it out. So how do you examine the AV fistula? You look, you feel, and you listen. Okay, what do you look for? Vascular access scar site, any signs of infection, any hematoma, any signs of ischemia, aneurysm, and then we can do an arm elevation test. Then look at collaterals that shows your central venous, you know, stenosis. Signs of infection: red, you know, warm to touch, pain, fever. Don't expect, you know, only infection can be for dialysis catheters. You can have infection with fistulas as well. Okay, so you get this, you pick it up early, start your appropriate antibiotics, the patient does well. Otherwise, the patient gets other, you know, infective endocarditis, etc. Again, the same, you know, look at the patient, hematoma. If this happens, there might be something, and you send the patient to your surgeon to see what he can do. Still syndrome, you'll see, you know, some patients complain of pain in the arms, cold, become blue. That's Still syndrome. You know, you might be having accessory veins, accessory drainages, which can be cut off, and that can help with the Still syndrome. Ischemia, you can see the ulcers there. Aneurysms, you know, we have seen this. So, you know, unfortunately, when you see this, you have a tendency, oh, this is a nice place to cannulate. Let's cannulate there. And once you cannulate there, you just increase, you know, that fistula. So again, avoid cannulating at aneurysms. So, you know, signs of unstable aneurysm, where there's probably going to be an impending rupture, thin, shiny skin over the aneurysm, prolonged leak, ulceration, and rapid enlargement. They need to be sorted out. Otherwise, these patients can bleed to death when they're sleeping, right? If the fistula ruptures. So one of the tests I'll explain here is arm elevation test. Okay, you have this artery vein. Okay, nice fistula. So normally when you raise the arm, the fistula collapses. Yeah, this fistula collapses, as you can see here. But if you have an outflow stenosis, if you raise the arm, fistula does not collapse. Okay, if you catch this earlier, send the patient treated, you won't get the thrombosis we had for the patient, for the case we presented. Is everyone clear with this? Yeah, we do this once a month at least. Okay. So central venous stenosis, you have seen this. We have seen a lot of this because of our vascular access issues. Yeah, patient has got number of subclavian catheters, temporary ones initially, then finally tunneled, and the patient ends up like this. And this is increasing your mortality. And then feel, right? We looked at feel. So feel, what do you feel for? To detect outflow or inflow problem, You look at your fistula pulse character, thrill, then we have a pulse augmentation test, and then sequential occlusion test, and then access versus non-access limb. You can examine both the limbs. So palpation, you have a nice compressible pulse there, and that's a nice fistula. But if you have like a really thumping pulse, then there's an outflow stenosis, or proximally, which is causing your pulse to be very hyperpulsatile, or what we call a water hammer pulse. So again, what about inflow stenosis? You have a very feeble and flat pulse, then you have problem with your inflow. Again, if you get this, send him to the surgeon or whoever did the fistula, sort it out early. Palpation, again, you look for your thrill, nice, continuous thrill. Again, if the thrill is not, if it's discontinuous or very weak, then you have an outflow stenosis. So I'll just go fast. So pulse augmentation, what is this? Okay, you have a nice fistula here, and when you press distally to the fistula, you have augmentation. Okay, this is normal. Okay, but if you have absence of this or absence of the thrill, then the pulse, the augmentation test, as you've seen, there is a problem with the inflow. Okay, so no pulse or augmentation, no thrill, there's inflow stenosis, right? So listen, what do you listen for? Brew is, again, both to tell you what inflow and outflow stenosis there is. So this, it's, as I said, it's a multidisciplinary approach. Okay, you have to have a very cohesive team: the nephrologist, the nurse, the vascular surgeon. We're trying to have things like vascular access clinics where you can do that more often. So unfortunately, we have a lot of lack of fistulas, and one of the thing is, it's like a vicious cycle, right? Your cannulation, you're scared of cannulation, the patient gets pain during cannulation, gets issues during cannulation, does not like the fistula, less fistulas in our dialysis populations, increased mortality. So it's a whole lack of fistula because of the skill of cannulation is not there because there are no fistulas to cannulate. So it's a whole, and I said it's a team's approach. Okay, teamwork, patient-centered. Again, nurses should be more towards, they're seeing the patients every day. They should be looking out for these problems, and referring them to the appropriate nephrologist, right? Because they are the advocates of the patient. Thank you.